called Using the RPS Competency Framework in Practice. And I've just put my title there. So by the end of the session, I think what we want to do is understand the key principles of the RPS. It might be very new to you. You might have worked on the own competency framework. So it's just understanding what the RPS is and how we're going to use it in practice. Going to think about how the competencies can be used to further our own prescribing practice and how to do that, identifying our own key strengths and weaknesses, and building an action plan to further our CPD. So those are the objectives of the first part of our CPD afternoon. So a little bit of an overview for those people who perhaps did prescribing a while ago, you know, or you know, perhaps didn't have the RPS when you first qualified. So this is the 2016 version, and I know Faisal's going to put a link out to you so you can have a refresh of it. It was first published, the Competency Framework for Prescribers, in 2012. And its main aim was to promote safe and effective practice right across the prescribing professions. Because obviously at that point, and since that point, we've got so many different professions who can prescribe, obviously independent, supplementary. We've got so many people coming, you know, on board, and also it's about thinking, you know, we've got all of our standards, haven't we, with the NMC, the HCPC, the GPHC. It's bringing everybody together to have a common set of competencies. It was updated, as I say, this version in 2016 is the latest version, and that's what we're going to concentrate on today. Utilises a set of common competencies, as I said, underlining knowledge, skills and behaviours which underpin good prescribing practice. And as I say, it's regardless of professional background, so it brings everybody together. Review was due actually in July 2020, but it's been massively delayed, obviously due to current circumstances. And I think the feedback that we've got is that it's going to be a light refresh of some of the competencies. So I can't see it dramatically changing from this version when the new version comes out, and it's hopefully due next year. And of course, we have to think about now the NMC, the HCPC, GPHC are adopting the competency framework into their standards. So rather than having different sets of standards, it is all about using the RPS framework going forward. So let's have a little bit of a rethink about actually what it looks like. So this might be very familiar to you. You might thinking, I saw that somewhere in a document that was sent around, but I don't really, you know, I've not really engaged with it. It's very easily set up, and as you can see, at the centre of all of our prescribing practice, no matter what we do, we've got the patient. And the term patient there has really been applied as a generic term. So, you know, service users, customers, whoever we want to call the people that we're interacting with. But the terminology the RPS use is the patient. And as you can see there, it's split up into different areas. So around the outside, we've got the consultation, and you can see there we've got assessing the patient, we've got considering the options, got reaching a shared decision, prescribe, provide information, and monitoring and reviewing. And that's kind of the nitty-gritty of our prescribing role, isn't it? Underpinning all of that, around the outside, we've got our prescribing governance, and this is the pieces that hold our prescribing practice together and allow us to expand our non-medical prescribers professions, what we're allowed to prescribe, how we're allowed to prescribe, and who can prescribe as well. So this bit is really, really important. And you can see there we've got prescribing safely, we've got prescribing professionally, improve prescribing practice, and prescribing as part of a team as well. Just going to check yeah, we're okay. I'm just checking the chat function to make sure you can all still see me. Okay, so this is a typical competency, and this is a competency number 1 that I've just printed out here. And the way the RPS sets it up on there is actually really good, because you can make notes, you can use it for your PDR. So please do make use of the resources that the RPS has put on there. So you can see here, if we look at competency 1, assessing the patient, and this is really where most non-medical prescribing units start, the V300, the non-medical prescribing that we do at all the HEIs. So we can think there about indicators about taking an appropriate medical, social history, medication history, etc., appropriate clinical assessment, assesses and interprets, investigations. And it could be when we're going through, because you've got 8 points there, that actually, you know, before you even start on your NMP programme, you're going to have some awareness of these competencies. Yeah. I've just got to let people in, I'm afraid, so I'll just stop a minute to see if I can. Bear with me. Admit. Okay, I think that's everyone.
Thanks, Anna.
No worries, thank you. So as I was saying, you know, before we start our prescribing journey, actually looking at those competencies, we might be able to, we are going to be able to take an appropriate clinical assessment, patient records, investigations. These are all things that we kind of come in our toolkit before we start that NMP programme. What we might not know is about adherence and effectiveness of current medicines, if we're, in nursing or allied health professionals. And for other people, your pharmacists, maybe actually the clinical assessment bit is the bit that's missing. But certainly when we start our NMP journey and when we start our units, this all becomes very, very familiar to us, doesn't it? About assessing our competencies and about how we meet those towards the end of the programme. What perhaps is less familiar is then how we use that competency framework going forward, and how we then assess actually where are we up to and take an honest approach of actually how our prescribing practice needs to be developed. So the purpose and use, just let me do that. Purpose and use. Well, the RPS has 8 key purposes and uses according to the RPS website. This is all this information off there. Informing the design and delivery of education programmes, and it sets our learning outcomes and also our assessment as well. So we are guided by NMC, HCPC and GPHC in terms of what assessments perhaps we have to do, in terms of actually what hours that we have to meet. But also then the RPS as kind of underpins our curriculum, underpins your learning, underpins a lot of the outcomes that are reached. So one of the key main purposes is to inform the HEIs and provide that curriculum basis. Another key one is to provide the basis for ongoing CPD and supporting revalidation. And this is where the focus of today really lies, is that how do we use the RPS now to go forward to support our revalidation with our professional bodies? What can we include? Can we network in order to maintain our revalidation purposes? And to help prescribers identify strengths and areas for development through self-assessment, appraisal, and as well as structuring feedback from colleagues. So it's really, really important, I wanted to call this CPD update, the RPS is for life, not just for the duration of the course, because we really can use it going forward. It's not something that we should just shelve once we've got our qualification. So what we're going to call about, what we're going to think about is self-assessing competence. And the focus of our group work today is about identifying where our learning needs are and our areas of development. And it might be a pretty hard task because you've met all of these competencies to have the sign off, but you might have changed roles, your P formularies might have expanded, your roles in terms of the patients that you're seeing might have changed. So it's good to actually take stock today and think, actually, where am I up to in terms of going forward with this competency framework, in terms of my own prescribing practice? And next we're going to plan. So how to address those needs, you know, how actually are we going to maintain our competencies? So do we need that support from our peers? Do we need to go observing again, especially if we're being asked to do a different role? Is there CPD courses that actually we might need to do? Is it identifying that learning? And then it's important after we finish today's session, so this, you know, even though we're going to do this within the next few minutes, actually then this can feed into some more reflective practice for you, and thinking actually, you know, if I did go out and observe, if I did undertake another CPD, we need to reflect of the impact of that learning event and then action that into our prescribing practice. So it's all a constant cycle, and I always say to people that come on my course, this should constantly be doing, you know, it's not just a tick box exercise. We're very used to revalidation now, and it's how we use the competency framework to support that going forward. So it is very, very much a continual process. Excuse me, I keep having a dreaded noise that keeps going. Okay. So a little bit arbitrary, but I think it's where we need to start really today, because today is about yourselves. It's about actually what your CPD means to you, how to take this forward. So there's a little bit of a self-assessment tool here that I've put together, where we can actually start to think about, have I, you know, hopefully we're not at 1, hopefully we've got no level of competence, but actually in some areas we might have a 2 or a 3. So we're starting at 1, which is no level, no experience in the skill area. I would hope nobody scores like that. 2, low level of competence, little experience in the skill area. Then moving up to 3, we've got an average level of competence. Up to 4, it's moderately, and then up to 5 is a high level. So it's just worth thinking about, how do we then apply that to the competency framework? So what we're going to do is an activity. So we're going to put you into groups, and groups 1 are going to have competencies 1 and 7 to look at. Group 2, competencies 2 and 8. Group 3, competencies 3 and 9. Group 4, 4 and 10. And Group 5, competencies 5 and 6. And what I'd like you to do is try and look at each of those competency statements on the RPS and think about, as a group, where you think your competency lies. And the whole point of this is actually then to start planning your areas for development. So it might be a good chance to network in, sometimes, you know, thinking, well, actually, I don't have any experience perhaps of antibiotic stewardship or public health remit. Where do I go to get that knowledge if that's part of my role? So what you're going to do in your groups is then to feedback. So you want your strengths, okay? So your 3 strongest levels of competency as a group, then your 3 areas of development, and then the 3 that you're going to action plan. So what actually are you going to do from the competency, looking at the competency framework statements and thinking about then, how do I develop my practice? What am I going to do in order to meet those statements? Do I need to go and perhaps do some more networking? Do I go and perhaps start having critical discussions? Do I need to perhaps set up a local forum? Actually, what can we do to you know, think about those areas of development and how we're going to focus those in practice? Then what you're going to do is identify somebody in your group to feedback. So please do identify someone, your 3 strengths, your 3 areas of development, and what you're going to action plan and how. So I've been flitting in and out of rooms, and I think there's some really good discussions that have happened in a very short space of time, really. You know, this isn't meant to be a finite CPD thing that we do here. And I think it's important to remember, even though we've only had probably 15 minutes to discuss that statement, you're all from different areas, you're all from different professions. And hopefully what this has given you is kind of a tool to go forward for your own development. So it's about, you know, your learning continuing after today's session. in order to think about those statements for your own CPD and your own moving forward, really. This is just a very, very quick snapshot in how to do it and to give you a little bit of a tool to do it. But it's important to remember that this is your development, isn't it, to go forward. So shall we start with group 1? And if you just give us whoever's been nominated, very, very brief feedback on which were year 3 high, which year 3 we're a bit unsure about, and what we're going to do about it. Who's volunteered from group 1?
This is going to be interesting. Come on, group 1.
Where was group 1?
Let's just take the names down. Who was in group 1?
I know Victoria was there. Who was it? It was Eileen, wasn't it? Where's Eileen gone? There she is. Here we are, Eileen.
I think Eileen's on mute.
You're on mute. You put yourself on mute. It's not me.
Maybe up.
Can you hear me now?
Yeah.
Go for it.
So we didn't have actually access to the statement. So we've just done a generalised discussion about Competency 1 and about how that applies to Competency 7, which in our case is the safety aspect of it. So we looked as a group at our strengths, and we felt that our strengths were our communication skills when we're talking to patients, and our underpinning knowledge of our own area of clinical, expertise. So obviously we all work in different areas, but we've all got specific knowledge related to those areas. And we thought that what we should be doing is constantly looking at ways of developing our practice and our skills, really. So then the way to develop that is to look at how we can do things differently. And we thought it was quite relevant at the moment with the way things have progressed, how we've had to change practice very quickly. I mean, we're doing lots of telephone consultations now, so you can't assess your patients in the same way as you would have done previously. You've got no face-to-face contact. You're just chatting to people on the phone. So we're looking at how we can expand our practice and different ways of working, and how we can achieve those developments is by maybe, so if you are looking at moving from one area of practice to another, and you do need to develop skills in that area, maybe looking for somebody who can support you in that, who's already competent in that, so you can go and work with them, shadow them, pick up knowledge and experience from them, and so that they can support you in the practice and in your development areas. And basically all of that we thought fitted in with the safety aspect, because everything you do, you need to have the underpinning knowledge and skills so you can do it safely. So don't know if that's what you were looking for.
No. I think that despite you not having the statement and nobody asked into it, I think that was very good. And I think what you did pick up there was the change in practice over telephone consultations, because it's always drummed into us, isn't it, that you've got to see your patients face to face, you've got to do this assessment. That's the way that we are safe, that we've got to cover X, Y, and Z. And now we're being forced into a situation where you have to do a lot of that over the telephone, where you can't physically see your patients as well, and still have to make prescribing decisions based on that. So I think that was really important to pick up on. That's been thrust upon you, hasn't it, in the last kind of 6 months. So it's how you maintain the safely. And it's interesting with the telephone conversations, because I think some people have that as part of their practice over and over and are very used to it. But for a lot of people, it's very new, isn't it, to assess people. And it's how you maintain safe prescribing in order to do that. And I know there's lots and lots of information come out, and Faz might be able to share some CPD or some courses where you can look at how to maintain prescribing safely over the telephone or virtually as well. It might be needed going forward. And for me as well, interesting, because it's something that I'm going to have to think about for my course, is how we do that and where the standards fit with that. So I think that was very interesting in terms of that. So thank you, Eileen. I don't know if anybody else wants to comment, please do put it in the chat button. But I think that was a really good start, is how we address doing that over the telephone and virtually, because it's a change. So thank you.
I don't think things are going to go back to how they were. I think things are going to progress on that level, really, because I think that's going to be the way of the world from now.
Yeah, and you need some education, guidance, some things to say you are going to assess these patients safely over the phone, and is what you're doing correct? Because, as you say, our standards have always been face to face, face to face, face to face. You've got to have this, you've got to have that, you've got to have the other. And we're now in a world where we don't have that. So it's, you know, it's remote prescribing, and the risks that go with that is a lot to consider, isn't it? So brilliant. And I hope you take that forward, Eileen, about, you know, your own learning development about how to do that and incorporate that safely. So thanks, Eileen. Group 2. Who's from group 2? That was Isel's group. Who's feeding back?
I don't think we actually got that far. Who's feeding back, to be honest.
Well, do you want to give an overview of where you're up to and who? I think you've just nominated yourself, actually, Margaret.
Well, I'm probably not at all the best person to be doing it, really, but never mind. Yeah, because I couldn't see the competency document, so it was a bit difficult. But I suppose personally for me, it was thinking about, you know, there's always things you really don't know, and you don't know them sometimes, because one of the examples was that Faisal mentioned was about one of the things about considering somebody's religion and what you're prescribing for them. And I have to say, some of the stuff that Faisal told me was a revelation, because I didn't know that. So I think it's sometimes when you find out something you don't know, is then pursuing that and thinking, well, what are the drugs that I prescribe that is actually relevant for? So finding out about that. So just from my point of view, that was one of the things that prescribing professionally, there's always things that you don't know that you need to then go find out about.
Yeah, and it's not until you start having these discussions with multi-professionals about other people from different areas and start looking at these statements to think, well, what does that mean for my practice? Sometimes we think, oh, we're fine, you know, we go about, but, you know, and we do our day-to-day prescribing practice, but it's not until you sit down with somebody else and you go, well, what about this and what about that? So I think that's important, because we're told about, you know, prescribing for allergies, aren't we, and unlicensed and off-label, but actually things like, you know, religion, ethical principles, perhaps the grey areas that we don't always consider with prescribing, that are important to our patients. So again, really good. I know you think you're not getting, but we're getting some real nuggets here going forward for people to think about and how to progress a practice. So I think for that one, you know, it is about that multi-professional, isn't it? About going through and going, well, what does that mean? You know, what does that mean to me? So thank you, Margaret. Anybody, have you got anything to add for that, Kaiser? Because you were in that group, weren't you? I think that was really important.
Yeah, I think just a point from me was, I think all of you coming back from different settings, primary and secondary care, I think it's really important to have this kind of forum where you can interact and share your experiences, because I think the main thing is, like, all of you will find that the competency framework, and you subconsciously doing some of those competencies without thinking when you assess it in your area. However, it's when you come across a patient where you have to make considerations about something that's not your specialist area, and how do you tackle that? And it's about reflecting on your practice over this last 6 months and say, what other patients have you seen, to be able to, and then really reflect upon identifying those 3 points, as Anna's mentioned, to say, what do you need to focus on going forward? And I think the next CPD session will be really good for you guys to attend as well, because it's not something that everyone does, and I'll talk about that later on. So it's really about not just focusing on your specialist area, but what do you touch upon as well. going forward.
Yeah, it is. It's the not knowing what you know until you have to come across it in practice and thinking, what do I do here? And these forums are really a way, and just to chat to other people is a really good way of doing that and progressing your competence. It's all there, isn't it? It's all specialist knowledge. Brilliant. Thank you for that, Margaret. Again, so we've had things like telephone consultations, we've had sort of the ethical, the grey areas of prescribing with religion. So that's all brilliant. Group 3, who's going to feed back? Got no volunteers. Group 3? Elizabeth, you need
I'll
to...
do it. Yep.
Oh, there you go.
Perfect.
Thank you,
Yeah.
Elizabeth.
Okay. All right. So we talked about, I can't remember what the thing, it was about gaining patients' consent, and talking around, are they, have we taken into respect their sort of fears and expectations, I suppose, around that. So we talked about, one of the girls works predominantly with patients in care homes and talked about having to put dolls in place and best interest, and are we working in best interest, and whose decision, and are we going back on decisions that they may well have made in the past. And then we talked about patients declining things like statins. There was one example of patient declining asthma treatment. I know I have a lot of trouble trying to persuade people, sometimes diabetes patients, to accept injectable treatment when that's where they are, is the stage of their disease. So we just talked around that and sort of chatting to the patients how to do it, but then documenting and accepting that actually at the end of the day, as long as it's an informed decision, it is their decision. So it's just but making sure that it is an informed decision. So going around that, Eva was talking about the motivational interviewing courses that are going on at the moment, and that might be a development need for us. Although we felt that generally most of those steps we do almost as a matter of course, not that we're all perfect, of course, but we do as a matter of course, in talking to our patients and informing them how and when they should take the medication. Then we also accepted that despite what we might sit here and think in our ivory towers, the majority of patients don't actually go away and take their medication every day as we've told them, which we can tell from their prescribing. How come your asthma inhalers lasted you 6 months when you honestly take it 2 puffs twice a day? But we all hear that all the time. So really that was about that. It was just, taking a bit more time, I suppose, to explore patients' expectations and fears about medication.
Oh, again, really interesting, and some real nuggets coming forward here, isn't there? And it was helpful to have that discussion with your colleague who works in the care home around mental capacity and dolls and all of these kind of laws that we put in and all of these checklists that we put in around medication. And sometimes it's not only about the legal stuff, isn't it? It's about the ethical principles as well. And I think ethics is something that kind of we forget, and ethics underpins a lot of our prescribing, is that should we, if people really, we can sit there till we're blue in the face and say, take this, take that, and people walk out the door and just not, they won't even get the prescription. I was in a community and I just used to open, cupboards in the kitchen and it was just full, of people's prescriptions. So I think shared decision making, all of this aspect again is really important, and understanding that if patient isn't going to take it, then we can document, but we've got to move on, and revisit that perhaps at the next, or work with them, as you say, to get a different pharmacological approach or non-pharmacological. So again, really important to do that, and thank you for highlighting, Elizabeth. Any comments on that one? Because I think that was really good about the dolls and the consent. And of course we shifted, haven't we, from Boland to Montgomery, and about the levels of consent and what is consent. So I think all of that is kind of something that we kind of think, oh, do we know it, don't we know it, what's going on here? So thank you for feeding back.
Okay.
Group 4. Yeah, Alison.
Hello, yeah. So within our group, there were 3 pharmacists and 2 of my nursing colleagues. So it was an interesting one when we found out that we were reviewing competency 4, because that's the prescribing competency, isn't it? So forgive me, I haven't got a copy of it in front of me here.
Okay.
So
We're doing well without it, I think, really, aren't we?
yeah. So I think as a group, we felt quite lucky. We've got quite a lot of experience between us all. And for those of us that are pharmacists, it's a bit different, isn't it? Because we're kind of like specialists in the medicines aspect of it. So when you look at that particular competency, our knowledge will probably be a lot better than some of the other prescribers. And also, not only that, we would know where to look to get that medicines information that we need to make an accurate decision on whether we prescribe or not. So, you know, we talked about the use of resources. So, I mean, we all agreed that we all constantly recheck and double check the BNF. And also our formularies like GMMG, NICE guidelines, etc. And what other resources that we would need. Now, within a hospital setting, it's quite different. Some of us will have had some medicines information training, and there are clear structures and resources to look at to make an informed decision. For example, if you had to prescribe a drug in pregnancy, and there's some very specific resources to check to make sure that you make the right decision. You wouldn't have that in the community. So it's knowing who to go to check that information. And we're quite lucky. A lot of us work very closely together. I know I've done a big piece of work with Lorraine's team, the extensive care team in Tameside. And so we were constantly bouncing ideas off each other, and people ask me medicines information queries. And so that's good. That's how it should be. It's knowing who to contact to double check the decisions being made are the right decisions. So that was good. And we also talked about, you know, all of us acting within our own spheres of competency. And I used an example, even though I've got, well, it's almost 25 years of NHS experience as a hospital pharmacist. I wouldn't choose to do prescriptions for something like oral contraceptives or HRT, because that's just one of the areas that I've never really kind of done much on. I've probably done quite a bit about 20 years ago when I first started, but it's a long time ago, and so I wouldn't choose to prescribe that unless I had to, and if I had to, then I'd have to bone up on it again. So it's knowing your limitations as well, and like they always say, act within your sphere of competency. So, and yeah, you know, like I say, checking all our resources for adverse effects, side effects, interactions, and we've got access to those. Most of us have got access to them, you know, electronically as well, which means they're always current and up to date, so that's good. So that was competency 4. I don't know whether anyone else in the group wants to add anything to that. Okay, I'll move on to competency 10 then. So this was about support, really, wasn't it? Competency to competency 10. Yeah. So we identified that our strengths really were being able to function as multidisciplinary teams, and I think we're quite lucky in Tameside and Glossop because our trust is an integrated care organisation, and so there is a good degree of integration going on already and multidisciplinary team meetings. And for the likes of, say, for example, myself and Lorraine, who's from the extensive care team in our group, we're all based in like one sort of area, and there's other teams based in the same area as well. And so you get to know about different services that are available. And then automatically you're thinking, I need to refer to district nurses, I need to refer to IUPT, or who you get to know who to refer to. And that forms a more well-rounded care for that patient. So it's not always just about the medicines and prescribing, it's about the total care of the patient. And I think we've got a really good model at Tameside to support that. And we've, you know, Lorraine said as well in the group that, you know, we've made some very good relationships with these groups and these people, and we, you know, good examples of networking. But one of the things we did talk about, sort of areas for development, really, within my service, which is the primary care network pharmacy team, there's so many different pharmacist roles out there in the community. And it can cause confusion, not just with practice-based staff, but patients as well. And so, as an example, within our team, we wouldn't necessarily do something like minor ailment clinics because we're not skilled up to do that. However, we may find that on the day when we're in practice, we've got a patient booked in for a minor ailment review. Now, what do we do there? It's because I think that the staff in the surgeries get confused as to what our roles and responsibilities are. So an area for development is just highlighting time and time again what our roles and responsibilities are. And it's really confusing for them. I do feel sorry for them because they seem inundated by pharmacists sometimes. So that's from a pharmacy perspective anyway. And I think really another area we talked about was having adequate support and supervision in place for us all, not just as prescribers, but also providing that support to the newbies coming through and things. And it's something that we don't really do. And I think a lot of that is down to time because it's a luxury and we can't really afford to spend that time. We should, but we can't really afford to spend that time to develop them. And one of my action points I jotted down was to maybe introduce some more robust one-to-ones with new prescribers, especially within my own team, to mentor them a little bit as a starting. So that's it, basically. I don't know whether anyone's got anything else from our team.
Thank you. That was very, very comprehensive. Thank you, Alison, despite not having the statements. That was really good, and it just shows about, you know, different professions, and perhaps, you know, you would look at the other competences and think, well, that might be more of an area of development for me. Everybody's going to be different, aren't they? And I think the multi-professional and the supporting people is quite pertinent now because of the standards, you know, and the DPP coming out, that, you know, you are going to be the future mentors. You don't have to have doctors anymore to sign people off. So this is something about, you know, supporting others as well, about, yes, we might be comfortable with our own competence, but actually, how do we feel about supporting other people now through this qualification? And it might be that you want some further assessment, mentorship, actually development that yourself in order to move forward with the DPP framework and be comfortable with signing the next generation of prescribers off. So I think that was really important, Alison, that you ended with, about actually feeling comfortable with yourself, but how are we going to support others as well. Okay, last but not least, and then we'll have a quick break, is room 6. Who's doing room 6? Anybody in room 6? Helen?
We're in 5.
Room 5. Oh, room 5. Oh, of course. I'm thinking, I've just made up another room completely, haven't I? That's why you were looking at me blankly going, what is she on? Go on, room 5.
Yeah, we didn't actually get as far as writing anything down, but we had a physio practice nurse and me from palliative care, so quite a range of patients really. But yeah, we sort of talked about obviously number 5 is providing information, and you know, it's really central to what we do as practitioners and as prescribers. I was reflecting on having moved from a job in May to this job where I was mostly seeing hospital inpatients, well, entirely seeing hospital inpatients for lots of years. I'm now seeing hospital and community, so I'm having many more patients who are not unconscious and therefore need a level of it. It's cool, a level of information more than you know, very close to end of life patients in hospital beds. So I've just been kind of considering that slight shift in what I'm spending my time doing. But obviously, even when the patient's not conscious, staff need information and families need information too about what we're doing and also what we're not doing. So that was something we talked about, and Preeti was talking about from practice nursing point of view, sort of the different areas and where her comfort zones are and where she would go for support with other specific disease types. We also talked a bit about how how the general public's medicines knowledge is really low, and how it's us that's not normal. I came to medicine, came to do nursing at 18, and I can't remember not knowing what the dose of paracetamol is. I can't remember not knowing that you can take that along with ibuprofen and it's absolutely fine. well, you know, barring anything else that's an issue. But the general public often don't have that at all, and will not necessarily do what we've asked them to do, but might do what Beryl down the road does with tablets that might look similar. Who knows why that is? And also the other end of the spectrum, the patients who are really expert patients and who can almost educate us. And Pretty was saying how it's great when you kind of really know your patients well, and you know who's going to need lots and lots of time to go through stuff and who's going to go, yeah, that's fine, I'm on it. And always meeting people where they're at, and not missing that gap where you're up here and they're there. And you sometimes see clinicians who think, don't, because there's a huge gap. You're talking up here, they're going, what are you on about? So that's always good to keep in mind, I guess. And then we had a little look. Oh, sorry, Barb and Pretty, do you want to add anything there?
No, are we okay?
No. And then we talked about monitoring and reviewing, and we're all pretty fortunate to be able to do that quite easily. We also talked about COVID and telephone reviews that Barb's doing a lot more of, and Pretty as well in primary care. Ooh, what's going on? And how that can actually be really helpful in some ways, and that reviews can be sooner by phone, but also some things don't lend themselves to on the phone. So inhaler technique was Pretty's thing that you can't really do on the phone. And we were talking about using online resources even to help with that, and pharmacists as well, where they can do face-to-face things. So yeah.
Brill, thank you. So that was a good round off. So communication, how we communicate, both on the telephone, how we change our manner, what information actually is need, and as you say, going from area to area, it's not just about the patient we have to communicate, but guardians, families, the support networks, people who might be administering that medication. We've got all of that to think about, haven't we? And bringing it back nicely to, I think, to where we started, which was COVID and telephone consultation, that our lives have changed, and how we assess people have changed, and how we communicate has changed. And as prescribers, we need to be on that, don't we, in order to still make sure that we are ticking those boxes, that we are still safe, that we are still effective. So I think that was really, really good. And even though we couldn't see the competencies for everybody, I think we've generated a lot of discussion, a lot of key themes coming out as well. And just from our point of view, making sure that you're doing this individually. Okay, so your CPD doesn't end here. Do it individually, go through, everybody will have those areas that they need to develop on, and then think about actually how you take that forward. So just some legal updates, and you probably know this already, but I just want to make sure, because I just wanted to do the legal side of it. So the Misuse of Drug Regulations 2001 and the Misuse of Drugs Act 1971 have both been updated with regards to gabapentin and pregabalin, as I'm sure you know from last year. So now they have both been reclassified as a Class C controlled substance, and is now a Schedule 3 drug, but it's exempt from safe custody requirements. And it's thinking about, should evaluate patients carefully of history of drug abuse before prescribing pregabalin and gabapentin, and observe patients for signs of abuse and dependence. And patients should be informed of the potentially fatal risks of interactions between pregabalin, alcohol and gabapentin and other medicines that cause CNS depression, particularly opioids. So this is the official line, and I think I just wanted to start with this just to make sure everybody knows that this has been updated from last year. And it's really the people it affects. Well, NMC and GPHC prescribing registrants can still go about prescribing gabapentin and pregabalin as an independent prescriber, as long as it's within your scope of practice and you consider everything that was on the previous slide. Who this probably affects the most is HCPC prescribing registrant who can no longer independently prescribe these medicines and must use supplementary prescribing. So that's a statement from the HCPC. And I do know, and I've been on again, and we keep asking every single time we get in our wider national forums about when the CD list is going to be updated, particularly for our physiotherapy colleagues who use gabapentin and pregabalin to manage neuropathic pain quite a lot. And at the moment, they're still saying next year. So we've not got that much, I've not got that much to tell you on it. You know, we're still hoping that they manage to get that through and update the CD list, because at the moment it's putting a lot of limits on practice and those patients that you are seeing. For everybody, because we've now been reclassified for those 2 drugs, it's just to draw your attention to the prescription requirements, and I put the B&F link there just in making sure, because sometimes we can forget that the pregabalin and gabapentin have gone on the CD lists and the prescription requirements are going to be a little bit different to the ones that we had before, the normal prescription requirements. So that's a bit of an update with the legalities, but I think what we want to go through this afternoon, and actually what Pfizer wants your feedback on, is our guideline update, which is nice, and it's a draft consultation. It came out in August, okay, and I think you've got a few more days to feedback. And this is for chronic pain in over 16s assessment and management. I've put the link there, and I think Faisal's also put the link on in chat, as far as I know. Just going to check chat. Yep, there we go. So it is there. It still is in draft consultation mode. So it's really important to read it and feedback. And what they've done is said it should be used alongside the NICE guidelines for specific conditions that cause pain. So headaches, low back pain, sciatica, rheumatoid arthritis, osteoarthritis, spondyloarthritis, endometriosis, and irritable bowel syndrome. So those are pain guidelines where you have got a specific condition that can cause chronic pain. This guideline is supposed to sit alongside those already existent guidelines. A little bit of an overview, and this is where I think it's going to be different for people. It includes recommendations on what it's calling chronic primary pain, as defined by the ICD-11, for which there are no other available NICE guidelines. So those guidelines are the other ones that have a specific cause. And what it's saying is the guideline aims to reduce distress and improve the quality of life by ensuring a care plan informed by a person's individual priorities, strengths, preferences, interests, and abilities. Okay, so it's sounding okay so far, we think. And chronic pain, so chronic pain definition I've put there is pain that assists or reoccurs for more than 3 months. That's the official definition. But what they've used in NICE guidelines there now is called chronic primary pain. And that is chronic pain in one or more anatomical region that is characterized by significant emotional distress, anxiety, anger, frustration, or depressed mood, or functional disability. So is it interfering in daily life activities and reduced participation in social roles? So it's not pain that has got an attributable cause. Those guidelines already exist, for example, back pain or endometriosis. This is pain that is characterized by pain in more than one place, and also by all the accompanying emotional distress or reduction in ADLs that goes along with it. What they said is chronic primary pain is multifactorial. It's got biological, psychological, and social factors that contribute. And to go along with that, they're thinking exactly what we've just said in our RPS, thinking about the importance of assessment, about thinking about communication, information, and shared decision making to go along with that assessment, which is everything that we've just said. But the important thing is, and I think where I think the debate needs to happen, is the implication for practice. So what they've said is, first of all, analgesics. So paracetamol, NSAIDs, benzos or opioids should not be offered. And what they said there is little or no evidence that they make any difference to people's quality of life, the pain itself, or psychological distress. So we're not looking at any analgesics. And there was evidence that they can cause harm, including possible addiction. So that was number one. They said, actually, analgesics, no. Anti-epileptics, also the same. Again, our gabapentoids, pregabalin, and our gabapentin, again, should not be offered. No evidence that these treatment works and could have possible harms. We've just looked at that as to why they've gone on the CD list. So again, anti-epileptics are a no. What they do say is that you could consider an antidepressant. So duloxetine, fluoxetine, paroxetine, citalopram, sertraline or amitriptyline. But considering these are going to be an off-label use of these drugs to treat this chronic pain condition. So they have said consider antidepressants, but obviously there's so many other factors that we also have to consider with antidepressants. So we've got quite a lot that's ruled out. One drug category that may be ruled in. So what have they suggested? Well, they've suggested psychological support, physiological, and acupuncture. And these are the only ones that they're saying we have got an evidence base to support these interventions within this chronic primary pain group of people who, let's face it, you know, come from everybody that we see. You know, sometimes we get these people that we just can't get their pain under control. We just see them, there's so much going on, and this is what they're calling the chronic primary care pain. What they don't mention is social prescribing, so you can have a look through that document and perhaps feed back that actually, you know, social prescribing is something that's coming to the forefront. So that may be something to consider when you have a look at the document and you feed back. And just some challenges. Well, these are ones that I linked together, and in a public health review that came out last year, and we're thinking about our local population, there was high prescribing rates of a lot of these drugs for opioids and gabapentins has been linked to deprivation. So if we're thinking about some of the people that we see in the Northwest and all the challenges that we're seeing at the moment, we've got some of the most deprived areas in the country, and we've got some of the highest prescription rates of drugs like opioids and gabapentoids as well. And it's how people that are already on those drugs. So how are we going to manage those challenges going forward? What's going on there? All the challenges, you know, it's very well thinking about exercise, psychological, but we've got to think about resources, what's available out there, how's this going to impact on managing this huge population closer to home. Time, certainly the people that these group of patients normally see are GPs, you know, with a 10-minute consultation, you know, to think I've got pain, what is the first thing that you're going to do is perhaps prescribe an analgesic without actually thinking. De-prescribing, you know, if people are on these, you know, these lots of opioids, if they're on multiple drugs already, how then actually do we start to wean them off? What's our de-prescribing approach? What services have we got out there actually to support this guideline going forward? What are the expectations really? And I've put there prescribers and public. So what are going to be the expectations of the public when they're mentioning they've got pain? They're going to mention actually they don't want to go and have exercise or talking therapies. They're going to want to come out with a prescription most of the time. So again, we've got expectations of the public, and that goes then along with education, doesn't it? Both of us and of the public as well. So I think there is a lot of challenges with this implementation. As I say, it's in draft form. There's a lot of indications that say actually, you know, what's the research? You know, is there any research that goes along with this? So I think it's a really interesting document, and I know Faisal would like you to have a look at your opinions on it. And to think about actually what are the challenges going forward. And I will send this PowerPoint out because there's a couple of case studies that might just help to do your CPD, because you're counting as a CPD. to go through and just think about some of the challenges that these case presentations might present to you. And that was a whistle-stop tour.